welcome everyone in the meeting room. Some more introductions to our activity today. So this is again Aliyah Evangelista from the AeHIN Information Network. Welcome to this month's first hour, our network's online learning and sharing session, which happens actually every fourth Fridays of the month. But today we're very glad to inform everyone that we're now expanding to having 2 sessions every month. That's our new schedule. That's every second Wednesdays and fourth Fridays of the month, 3 p.m. Philippine time, using the same platform, Cisco WebEx online meeting. We're broadcasting from the National Telehealth Center in Manila, Philippines. So today is April 20, and it's exactly 3:05 here in the Philippines, and we are very privileged to have Sameer Pujari of WHO headquarters as our speaker on the topic health for non-communicable diseases. Some before we start our session, we're using Cisco WebEx as platform for this meeting. If you are encountering problems on your connection, please log out the session and rejoin the meeting room immediately. Your mic will be muted during the meeting, and if you have questions, you can type it in the chat box located at the right panel of your screen. Click your hand button if you want to raise your questions directly to our speaker. On moderator signal, he can unmute you so you can ask your questions directly to our speaker. Our meeting, do not forget to accomplish the evaluation survey of the session. And once you accomplish it, we're very happy to send more information, resources, and other readings of our topic to you. And lastly, my favorite for everyone, please stand by for a photo-taking session so we document your virtual presence in this AeHIN Hour. That's some 5 points for you to remember. So you're ready to participate? Let's start the session by knowing our speaker this afternoon. Speaker Sameer Pujari is a public health informatics expert who has earned his PHI fellowship from the Centers for Disease Control. He has worked at WHO headquarters on global health surveillance, and it involves, among others, the use of electronic data management technologies, supporting the data management, planning, and setup for national-scale surveys. He also provided support to 25 countries in the WHO regions and had many training and capacity-building sessions on implementation of surveillance. Since this year, he is co-leading the development and implementation of the new joint WHO and ITU initiative on mHealth for non-communicable diseases. So please welcome our presenter speaker for this afternoon, Dr. Sameer Pujari. Dr. Sameer.
Hi. Thanks for that very warm welcome. I'm ready to speak at this session. I have the slides on display when I talk, or how does it work?
Sameer, I role as presenter. So you can now control the button, the shared desktop. There you go. Thank you very much. While working on your slides, I would like to welcome in our meeting room our friends from Thailand. I saw one and our friends from the Thailand Health Systems Research Institute. Hello, and thank you for coming in our.
Okay, see my screen?
Yes, you can now see your screen with a lot of tabs. There.
Can you see the screen which says fighting the global health burden through new technology now?
Yeah, we can now see your screen. You can choose to click show. Okay. Sameer, I hope you would speak slower so we could end what you are.
I will feel free to stop me at the stage if you think I'm speeding through.
Okay, thank you very much. So I give you now the floor to the presentation.
Thank you. And good morning, good afternoon, good evening to everyone who's online. It's very exciting. I'm excited to present this to this webinar session for the first time, talking on our new program at WHO and ITU on the mobile health sector. It's come a long way on the political side, and now we are into the field. So I'm going to try and basically talk to you through presented very warmly. My name is Sameer Pujari, and I work at the headquarters in Geneva with the NCD department. Is to lead this joint initiative. And I met Mark Landry in Wipro earlier this year when I presented in our regional office in Western Pacific. And he said he introduced me to this group, and I'm very pleased here to speak about this program to the group. Feel free to stop me for any questions or if I'm unclear at any stage. What about a very simple structure? I want to speak about what the initiative is or what the program is about. Why this is an important program for us at the UN community, and how this has come out. What is the issue around this? I wasn't very sure about the audience, so if there are some slides which are more technical and some which are very boring, please bear with me because I've tried to have a balance between the e-health community and the public health community in general. To start with what? This will be a very basic slide or a very complicated slide. This basically gives you the context of what non-communicable diseases are. In this, we at WHO are looking at all the diseases not communicable in structure, which are not spread to communicable media. And you see the main diseases are diabetes, cancer, chronic diseases, and cardiovascular diseases. So these are diseases, and the roots for these diseases are lined below the tree, if you see. Slide just gives you context of what NCDs are, or what are the problems, or what are the key points of NCDs. Next to the same slide, tobacco use causes all the NCDs. Unhealthy diets is responsible for 3 of the 4. Physical activity, and same for alcohol. So all these diseases are caused by improper human. There is a discussion in the NCD community that this is a problem with developed countries only. They don't face this problem. They are more worried about the MDGs of communicable diseases. And this slide gives you a snapshot of the facts. Is basically that this non-communicable diseases is a big problem across the globe. See from this slide, the problem is people die obviously, but the problem is also the deaths before the age of 60 because of NCDs. As you can see, it's equally represented across the globe as well as similar proportion in the developing countries. Well, that's the side of it. This is the more general. It basically means where we were at and where we are going towards, and this is a big problem walking ahead in the lifestyle. We've talked about public health terms. It's a huge component, and the government's realized. Harvard and WHO came out with a study before last year, quoting the global economic burden of non-communicable diseases coming to what $7 trillion of lost output until 2025, and it's humongous from public health and government economic standards. Key to that was what is the actual cost of making an impact, and the cost is $170 billion, and the details are in the document. But this is an impact of why NCDs is a key priority. And the footnote says that 50% of the deaths globally are because of NCDs. Not true, obviously, which was realized by public health policymakers. And so the United Nations, for the second time in its history, health issue as part of the UN General Assembly. The first issue which was picked up was 10 years ago, almost 10 years ago, and the first time when United Nations General Assembly put on a health issue, and that was for HIV/AIDS. 10 years to that, a second health issue has come up as a huge burden, and that's NCDs. And that's why it was raised at the high-level meeting, and a lot of policy plan was made at that meeting in September 2011, year before. What NCDs are about, and what is the for NCDs? Now the question is why are health? And of course, and this is old Psalm 9, which I still keep in my presentation. I like to present this. It shows the outreach of why the business for mobile phones is out there. At the end of 2009, we saw that almost half of the world's population had an access to cell phones. Say this is 2009. Why are you quoting these numbers? This gives context. I have another stuff here from so by 2012, they said mobile phones and human beings, which means in of 3 years, mobile operation. That's a good sector from mobile industry's point of view, but from a public health opportunity, that outreach, you've got a community which is doubling and tripling in a small span of time to every individual almost on the planet, and is that outreach to be used by public health. And some opportunity. I mean, there are other strong, and health is very important. Basically explains there's a strong system delivery mechanism available to us, which we need to put in very quickly. There is no growth is going on. Even in 2012, if you see the outreach of cell phones, is number of devices 1 billion. It's going to quadruple in 5 years. So it's humongous growth. And spread across the globe. It's not specific in developing nations or one continent or two continents. It's equal across the whole the globe. Obviously, the Asia Pacific is much more higher. The Middle East is much more higher with the penetration, which is much more interesting as well. I just want to put this out to see that the global leader is also identifying mHealth as a key component of delivery mechanisms in the future. So when we'll be talking of mHealth, there are a huge number of conferences held. What is the problem? There are many. Here's the problem. Millions and millions of pilots have been trained, but none have been taken to scale. The question is, evidence is there what like that? The basic people trust in mobile phones. So the first little thing, will they trust it with their health? Well, they trust. I as a person, in my money than my health. That's what. Well, if you're banking, you'll be able to trust your health phones from well. So what we looked at the evidence piece of it. So what is trust in cell phones? What evidence behind NCDs? Whether mobile phones are really effective? Thousands and thousands of pilots. Okay. The purpose of this is if it's working, you keep on going. If it's not, you stop it. But pilots keep on going on. What happens? So we're looking at evidence. Is there real evidence that shows cell phones work? We did a lot of programs and projects that have been happening over years at WHO and ICU. Most on non communicable diseases across 3 main areas of prevention of disease, treatment, and enforcement. The gamut of things in prevention. We saw awareness, we saw how training was effective, social networking, gaming. These are all components of mobile phones. Agriculture, where it all started originally, the ways in the terms of tobacco control, diabetes, physical activities, and then saw on the infrared media, which I'll talk about. To give you something we found, and these are very few examples of the humongous studies we did. We found that it works, and scientific evidence. Early last year in 2011, I think, came out of using SMS messages, just messages that cater to people. If we could turn down the number of smokers' quit rates 2 to 6, what that means is even normal service without SMS-based mechanism versus a mechanism where I'm using SMS-based systems, there's 2 to 6 times more likelihood of people quit smoking. That's a huge. We've seen big evidence for diabetes management just by informing people about care of diabetes. There's studies which show with the cell phones, the losing participants through SMSs, through just messaging, through reminders. There's evidence around that. Advocacy works. A huge program run by the European Commission called ex-smokers shows significant amount of awareness spread in the youth tobacco and anti-tobacco campaigns running around. Studies show how physical programs and ed-based programs help improve the healthy lifestyle in people. There's scientific evidence to it. A lot of people have been doing, and that's pretty much an evident cause that it's much more faster, much more. You can cover different domains. Being faster data collection and analysis helps you foster policy, and which makes a public health impact. And we've been doing for quite some time this evidence piece of it. Another of impact and effectiveness was training. Unfortunately, the public health community has not used it as much as the world community and the UN communities, including UNICEF, the UNHCR, the emergency groups, were trained. It's fantastic media. You're sending out messages, small components of the study courses on a regular basis. They go through courses over time at their own pace, by message, by paragraph. They trained on how to implement. They have access to the trainers. It's virtually everywhere in the planet. That's a cost-effective and simple mechanism of putting things. A lot of evidence on how this has been. A lot of groups already working on this. The tools exist. It's just the public health community. About the third area of enforcement. Very, very innovative piece of work in different areas of enforcement that have happened. From China, in the Shanghai Expo and during the Olympics in Beijing, when they used self-geotagging to inform people of smoke-free areas, like enforcement and encroachment. This is once you would enter the complex of the expo or the big stadiums, you would just saying that these are smoke-free zones, or you're not allowed to smoke here. Please report any encroachment to the people back at this specific number. You're spreading awareness as well as you're doing enforcement of policies, which is a big challenge to governments at a lot of times. And a very innovative way of treating illicit drugs. This example from Africa, and you've heard about this, is where there were people, and the problem in Africa was counterfeit drugs from the area. A lot of the manufacturers were creating medicine and selling it as counterfeit products in the country, causing a lot of public health issue. What mechanism came out was the boxes, they put a silver foil strap. You scrap it off, and you place the number to a toll-free number. You get a message back saying it's a counterfeit product or a legal product. Within 1.5 months, issues were almost 85 to 88% in the country. Fantastic of treating of encroachment. We have examples setting out. What I did was a program was we need to take this to scale. These are fantastic examples of public health solutions we want to do. We started on the second end. Yes.
Hello, Sameer. Before you go on with your slide, there's a question here from Cambodia from Dr. Sambat. A while ago, you showed a screenshot of a phone and application in Chinese. So he's asking if how do you, as an expert, address challenges in local language for SMS and phone? Or do you address challenges in local languages used for SMS applications? I think this is what he's asking.
A good question. I want to mention. I'm just going back to a slide which is here on surveillance piece. I think these days we have a very enhanced mechanism, and then there's a community gap of technology available. All languages can be adapted to different settings and phones. We are thinking the phone companies are thinking ahead of us. They want to sell the product, so they're already addressing all the language issues and all the challenge, all the language components of it. I come to a question as I go into more details further. I just want to give a snapshot of what has happened already with surveillance for mobile devices. And the first question that came to us was the same question that you posed about the different languages. How do we adapt it? The mobile these days are pretty smart to recognize all the languages. We are going much faster. Even simple dumb phones can recognize different languages and dialects. We've done this for the last 2 years in 50 languages across the world, with more than 31 countries using surveillance. India had 20 languages, all different fonts, different structures. China, Pakistan, Egypt has different scripts, different writing styles. The Arabic script is from the left. These solutions that can handle these. So I think for us, the concept, what happens to the public health community is we start thinking too much about technology, not knowing technology availability. We are much ahead of technology that's available already to us. So my point is, the solutions already existing in the technology world. We are not the first ones doing it. And I think the community is to try and see what solutions we want to put in and how we use best the existing models. Does that answer the question?
Very much, Sameer. I think the very important part on your answer to that question of Dr. Sambat was that mobile devices are very smart tools because they're actually used for local communication of people. That's why they could easily adapt to phone applications, specifically for designing and surveillance tools. So, thank you very much. Another question again from Dr. Sambat. You have shown a while ago a slide on experiences using NCDs in Africa. He's asking now if you have any practical experience on designing mHealth solutions for screen projects such as that of cervical screening.
Yeah, let me come to that question as I go through my presentation. Let's hold that question. I will talk to you about a very important model called Wakaya for screening. Can we hold on to that question as I go into my presentation towards the end?
Okay, that's just okay. We can move on to your presentation and we'll reserve that.
Okay.
For a while.
Basically, what said the first we saw the evidence existed. There's a lot more that we can share with the if there are people interested. Actually have a paper which we have just submitted which summarizes a whole bunch of studies. We have that. But there's a lot more happening. Then with commitment, is there interest in the market for mHealth? And there were studies and reports which have been coming out recently from authors, and these are some of the people we've talked to, very few. Interest. They see a huge opportunity for business and for service delivery using cell phones. The change in mechanism, and the industry is looking at it. When this came in, and the strong media of communication, that's where all advertising started, all the media started on television. This is considered a new generation of communication, and there's a lot of interest. What is needed from it to make this happen? So the question we've seen challenges, we've seen mHealth. What is needed? The question that is needed is political commitment. That's where it all falls apart. With small groups coming in, companies coming in, small NGOs coming in, doing pilots and moving ahead. Move further than that. It doesn't get communicated. It doesn't get communicated to the policymakers. And I think a big challenge lies ahead is the political commitment. Because, of course, if there's no political commitment, donor interest will be a big question mark. That makes something happen. You have an NCD burden and penetration. The two problems below are already prevalent. I'm not focus on the top two problems, which is donor interest, and obviously that will be from political commitment. Sectoral partnership model in public health. One, public health work with hospitals, with doctors, with medical people in-house. This is different. The first time involving a new community of work, it's using technology to come into place to help health. And so we need a very cross-sectoral partnership model. And that this program that we're looking at is basically aiming to achieve an example in context how we've done this and what we'll look at for the other countries. The key is transparency and accountability. Why is the key function? It allows you transparency with your political policymakers, with your donors. You can put live information through very transparent information to the policymakers, to individuals, to the donors, everyone. That's as a public health program at scale in strength, and that's what we want to sell through this initiative. That's for everyone. I mean, I don't want to talk about specific benefits, but we used to sell everyone. So there's a lot of benefits which have been detailed out. Background information, how did we come to this initiative? So we have political commitment. We have to raise political commitment. And it was through the research, a joint program, the first time for NCDs, a joint United Nations program between WHO and ITU. And for those of you who are not aware of ITU, ITU is the International Telecommunications Union, which is a specialized UN agency for telecoms. They regulate all the telecom companies, all the hardware manufacturers, soft companies that work in telecoms, and that's a public health agency. And this is a snapshot from the news that happened at the World Telecom in 2012 October, which had the health minister of Costa Rica, senior diplomats from UAE and from UK, and a whole bunch of vice presidents, directors, CEOs who were present at the launch in Dubai. This was in October. When was basically launched. What we do is to solve the problem of this mHealth issue that we've seen, this problem of pilotitis, running. What we do was bring a convening platform for regional levels, country levels, global levels together under one single structure, bring the best practices of mHealth together and translate that to the world. So, for example, Africa has done something on illicit trade. We want to bring examples. We not recreate the whole new model, the best example, and adapt that for different settings. My next example can be adapted to cancer drugs. It's a huge problem in developing countries. Counterfeit. How can we get that model? That's what we want to bring in. That will have effectiveness. And hence, if you pilot them, are always expensive because it's putting the cost first time. But if the transfer of knowledge is very effective and cost beneficial, and bringing on the local stakeholders, you cannot do a global successful program unless it's owned by the government and within the country. The objective of this program is to build capacity of the local stakeholders, NGOs, e-health community, mHealth communities, to bring and push this further, and then use the best practice cases to spread the world so that you can replicate a model instead of reinventing the wheel every time, which much most likely happens. That was a snapshot of how this is being identified by world leaders. There's a strong the UNDP head administrator, Helen Clark, talking about initiative being strong future public health mechanisms. So there's a lot of commitment, political commitment issue coming in now. This is the broad structure. There's a steering committee to the program that run the global operations and will support the country. And the way to do this is the informal expert groups from different experts and training experts group for cessation work, for diabetes and diabetes, expert groups for evaluation, cost effectiveness, expert technology, who will provide input to the steering committee and running this program, a typical program. Example of Costa Rica, which was the first country, and how they've made a successful mHealth model intervention in the country through this initiative. Costa Rica came to Geneva last year, and said, I want to make a health impact for NCDs. What is the solution? I gave it to the president, and he said, I want to make it happen. It's everything, obviously, but you have to have the classic example. The press office said, we committed, we want to do it. He said, no president would just say, I will put in $1 million. She saw the potential, and basically was convinced through this, and put in the first $1 million to the program. The president makes sure that everyone is working in. There's strong leadership from the Ministry of Health, and very importantly, this happened in isolation and coordination between the MOH, the Ministry of Information Technology and Education, and the e-governance group, all convened and worked at. The fantastic was yesterday. The program was launched in the country already. It was in January and in April, within a period of 4 months. People had all the infrastructure. We use models from across the world, the best practice models. Within a period of 3 months, we were able to launch a program of structure, and this is a country-scale level emission that Costa Rica is putting in. For example, it's a win-win countries, and there's no reason why the president would just say, I will do it, because she saw there's a benefit to it in the long run at scale. And at the end of it, it all boils down to money for the government, the economy for the government. That's what we're trying to explain this initiative or the program as a cost initiative for the countries with impact. Example of a very simple structure of an M program. The big gain around M program is, or M issues are, people often do things in isolation. I have an mHealth program to just track smoking cessation. So you can smoking cessation, have a small control group of 100 people, right, and say this is my smoking cessation. It doesn't show impact on policy. You find it has to be health system component to it. You have to have full gamut of things that are impacted. You can do cessation in isolation. It has to at a scale by prevention level, by informing the non-smokers, the population, the possible smokers, by health workers, by health enforcement of policies, by providing current smokers mechanisms to quit, and measuring what is the impact so that you can improve that. And you can all do this with mHealth program. not just a project or a pilot. This is how things are happening across the world. And question that was raised about the cancer screening. This is UAE, which has used model called AeHIN to screen all the entire population for factors, not for cancers, not only for one specific area. What it was a phone to measure and screen the cancers. It was a program to spread awareness and making a component of it where every person had to measure the NCD risk factors and public health or so they could do it themselves or go to a public health clinic and do it and measure it themselves. That means through a mobile system you can a screening model, and I'm happy to share the Wakaya model which was used in UAE, Abu Dhabi. This was a country, obviously that was commitment from the government again, using a mobile platform, mobile mechanism, and an electronic mechanism. It's eHealth plus mHealth, both was used in Wakaya. Screen the population for all these risk factors. Of course, this screening was part of that whole process, but also to the very basic early determinants of any possible risk factors, high blood pressure, sugar, other cancer risk factors, breast cancers, all those areas were being measured. Emphasis is put on screen points of it. But as I'm saying again, it's not one program in isolation, it's a comprehensive gamut program that you want to put into place. These are some screenshots of case studies of how the programs have proved effective to individuals in the thing. I am not aware of the whole audience group here, but what I just want to leave you with a message. What can you do as an e-health community? At this, I think the first challenge stage, we have solutions. As I said, the technology solutions are available. What we need to do is educate the people, the public community about the existence. And just because there's strong potential, there's evidence which people haven't seen, and communicate. Use existing models that are present. People who have done these. And replicate this model. I'm always at your service from WHO. We are willing to help countries interventions and help grow the technology solutions to make a public health impact. And that's pretty much what I had to say this morning. I'm happy to take questions.
Thank you very much, Sameer, for your presentation. We welcome more from our team this afternoon. But before that, I would like to recognize additional participants that we have this afternoon. James Rarik from Vaidya from Nepal. Fan Dor Anis from Indonesia. Kailu and I think the strong point that we have, that you have mentioned a while ago, is that mHealth is very important in disseminating information on non-communicable diseases, educating people about how it could be prevented, how it could be cured, and how people could adapt to existing mechanisms to fight non-communicable diseases. Any more questions from our team? I would like to have one of our participants have a short speaking share her insights about the donor or funder on activities and project doing on mHealth, because in this meeting room we have participants from GIZ who is a very supporter in our network. Fatima, do you have a microphone? Would you like to share what we have been talking a while ago in the chat box? Okay, go ahead. You can share your innovative GIZ initiative on linking cases for pregnant women.
No, this is GIZ.
This is done by USAID, not GIZ. But maybe you can share your SMS.
Sure.
Yes. Hello, we can hear you now.
Fatima from Bangladesh. Actually, in Bangladesh, USAID developed a project. It's a Mama project. Is for pregnant women. It's called AeHIN Hour. In any family, anyone in pregnant, like she got messages for 2 months about their health. Also, not only she, but also his family member got the messages from phone company project. This is happening here. Also, another thing, working in our Institute of Health, Ministry of Health. Another job that is the telemedicine. Then the community health, community clinic. People comes from the society and there is a community cover. They talk over Skype with her, sometimes over mobile, and serve they give the medicines and some other documents. This is ongoing. And for GIZ, we are not at this moment. We are not using the mobile health, but we are doing integrated information systems. Mainly for health ministry, we are working. We are developing the central data warehouse from and plan for future. Create the medical systems. We are using OpenMRS. For GIZ, OpenMRS and integrated system. Thank you.
Thank you very much, Fatima. Interesting. The Mama project was, again, as I've heard, was being supported by USAID. IZ is more working more on databases and information system for non-communicable diseases, not really on kind of mHealth, some kind of for disseminating information on mHealth. Another question from Dr. Iris from the Philippines. Doctors ask, is there a push toward, this is directed to Sameer, is there a push towards developing applications that run on SIM rather than standalone applications?
Can you say again?
Okay, I will restate the question. Is there a push towards developing applications done on SIM or SIM rather than standalone applications?
I think are not existent as much because the technology is changing. The cell phone mechanism is changing. It's all run through mechanism. It's what we also talked with some of the hardware manufacturers is going to device level implementation. Hello.
I'm sorry. I think.
Yeah.
Okay. Just admit one part.
Yeah. I think there is a balance. What we are trying to do is not push one technology because there are different technology solutions across the world and different countries have different priorities. What the push is to keep up with the technology through the development of tools. Again, as the health community, we try to push too much about the technology rather than the health side of it. What this program is trying to do is push the health piece of it. Technology exists and keeps on evaluating. innovating, and you discuss something, this new solution already available, and technology moves throughout sectors. While banking moves quickly, there's S-based mobile banking, now it's app-based. In some countries, not very prevalent, but that basically keeps our focus has to be on the solution, the public health solution, and the technology will adapt itself to it.
Thank you very much, Sameer. The most important message that I got from that is that we should continue to adapt to technology as it develops, but the more important thing to keep in mind is to focus on the solutions that we wanted to develop from the available resources and technologies that we have. Okay, thank you very much, Dr. Iris, for your question. Another question from our team from Thailand: how do mobile applications interoperate with information systems to exchange clinical data?
Systems that are happening in developed countries, that's going more ahead of I think what we're looking at this stage is we're talking of the final stage of using clinical data to combine with mobile health data. Again, some models from countries like NHS in the UK, the Kaya model have done that. They've integrated the mobile data. It's all interchangeable. It's all integrated happening. And just to explain how this happens, let me give an example of mobile finance or mobile banking. It's very synchronous and similar structure and technology available across this platform. Also, they have talked to each other. There's a protocol that have been developed in different areas, and you can synchronously across different cell phones, different networks, different computers, different browsers, go through and access financial data securely. Same for health also. Now the question is that health data available? Is a big question. I mean, a lot of countries are still struggling at getting hospital data or clinical data. That was place available in an online mechanism. So what probably this mobile phone-based intervention is helping it jump towards pushing that further with solution tool versus looking at the broader spectrum. I think what we need to focus at this is providing basic public health services as a start to cell phone. And what I would call on this e-health community is to spread that awareness within the policymakers, ensure that of the e-health agenda, the NHealth agenda captures these ones as an important health mechanism to provide input. Now, we're not saying we're replacing the health systems. We're not saying we're going to take away the doctors and give cell phones. Add on, let's make it very clear that a patient who has cell phone access has double information. The doctor can reach him at any time. He can reach the doctor at any time. He gets information on an ongoing basis. So we need to capture that to the population level and to improve general health process people. The specifics of how the specifics of data are of clinical data availability and all those things goes to very specific levels of people. And public health, population level impact on health.
Could you repeat what you said for the last 5 to 10 seconds, because you're a bit choppy. What we got was that we need to advocate to policymakers that interoperability is with mHealth application true, and then
it's not an issue and can be easily resolved. It's a technology solution again. Interoperability. You can switch telephone numbers. You can have SMSs from one library to other library, one provider to other provider. It is synchronous already. So there are technology solutions which are available to make this talk. And to explain that, I wanted to give the example of the mobile banking, how it works in the broad structure, how it's interoperable, and something applies to the health sector can be applied to the health sector. My push was, we're talking of public health and community, and what we should focus is not gated solutions, but very simple public health messaging solutions to start with on mHealth. Explain to the policymakers that having these population-wide health messages will be an add-on to improve the health of the population instead of into very complicated mechanisms of mHealth down the line.
Okay, thank you very much. Sameer, hope Sameer was able to answer that question on interoperability with on hospital information systems. Another question from Indonesia. How of SMS services sent to patient and their family? Is it preferred to be paid by the government or patient?
That's the costing of it. It depends. In a lot of the services, the first thing is more temporary the cost of SMSs or even the data used over on smartphones is down drastically. And the industry predictions, the telecom industry predictions are that this will go down much farther. So it's going to be a smaller and smaller issue. Now, the pattern it will start is when we start a program, health services program, ownership, and put in an initial cost to this process, to the cost through the government, all there will be a specific cost which they will pay for in the beginning. But then it could, if people see benefits in some developed countries, people are paying themselves for health services. Now, if I'm in countries in Africa and some places where people don't want to pay for health services to start with, an example of agriculture, mobile agriculture, in India, in a lot of African countries, it starts services by the telecom to get people informed, by the government to improve the productivity and agriculture of the agriculture. But the farmers saw the benefit out of it, more and more knowledge about how to have better crops, and they started to get advanced services, and they were willing to pay for it because there was a benefit for them. They make more benefit of the services that they were availing. There was a benefit to them, there was a benefit to the government, there was a benefit to the telecoms. Same applies to public health. The start services, we provide information to the health workers. When it's beneficial to them, they might eventually come to a stage where they say we will own this, and then we don't have to pay the cost. Even if the governments have to pay the cost of it, if you compare the cost of compared with health systems delivery that they have to give to, it's a huge difference.
Yes, very well said. Thank you on that. Because a lot of an SMS cost, but the thing is, as you have said, the cost on SMS by telcos and where as time goes by, and therefore making mHealth for mHealth plans such as pre or postpaid would be affordable. Pilot Fund from Indonesia is asking about security and privacy issues in applications. But you have said a while ago that most health applications could be compared to mobile and banking. So how does mHealth and mobile and banking solutions fare from each other? Privacy and security.
It's a technology solution. When you access your browser on the computer, you're using a protocol, it's a secure protocol. For health, you're using for shopping, you're using for banking, everything, the same protocol, the same technology. Same of cell phones. I mean, the data you access. It's about getting, and all this data can be secure once you do the application systems. The applications that are being built are already considering the security because we're concerned about uh, and so the basic point is technology solutions for security are available. You can put behind encryption which is floating out so that people don't access. Those solutions are existent. What we need to focus again is this is a scale thing. I mean, data is a question mark. It's always been a question mark for every technology solution, but there are things which are coming out better and better. So I think same applies to this thing as well.
Very well said. In a time wherein we use AM for getting our money, for withdrawing our money, and our doctors are still using paper for health records, is it good how technology is being used for more benefits? I think the most important thing to keep in mind in the privacy and security, as you have said, is that solutions are already available and it could be adapted in on mHealth. I hope Dr. Lutfan Sameer was able to answer your question. Another request from Ms. Ero from the Philippines. She would like to have a link of mHealth applications that are being deployed in various continents. Would I like to request from you, Sameer?
Yeah, we're working on a platform which will have all these applications in one place. But trying to do this is again a process where we engage with the countries. Where they can. I'm happy to share a couple of researches that we've done, which puts all the applications. Now, obviously, some of them are paid, some of them are free, some of them are used by private sectors. But if the country is interested and there's interest from the policymakers, what we do is then we bring this platform, we bring these tools to the platform, and we try to make it in a synchronous way which can be available to everyone. But I mean, I don't have access to all the tools, obviously, at this stage, the mHealth tools, which are being deployed across the globe. What we do is a review of these and best practices which are being there. What we do is we, based on country's requirements, we adapt these to the country settings and help them deploy it. So, if of interest, the list of projects or studies, but I'll have a side discussion about what is the rest of the country.
Okay, so I think that's it. Saying thank you very much for the last 35 minutes because it's a very overwhelming session that we have. We have a number of participants from, I think, in this afternoon, and we're happy to know that there are a lot of interest on mHealth, most especially to our AeHIN member countries. Most of our members in AeHIN are government officers, so we are being ensured. I hope we could be assured that what we have learned this afternoon would be translated to more specific actions and strategies in the respective ministries of health and government offices. Thank you very much, Sameer. If I would ask to close the session, could you open your video cam for to capture your virtual presence in this AeHIN Hour? Would that be?
So I switch on my video, is that what we do, or?
Just have to switch your video so that we'll to see everyone. Hi, Dr. Sambath and team. They're supportive colleagues from University Research. Mala Darna from the Ministry of Health of Sri Lanka. Hi, Fatima Udin from Bangladesh. Migo from the Philippines. Mohad Ulaji from GSF, and for our friends from always lagging. Oh, on my count, I hope you have your best smile for this afternoon. 1, 2, 3. Thank you very much. Another one. Thank you very much for attending this session. Again, this is Ali Evangelista from the Asia eHealth Information Network. We're very happy to have you this afternoon. I hope you join our next session on Friday of our month. That's April 26th, same 3 p.m. Philippines. Hi, Dr. Anis, Dr. Lutfan. Thanks for joining us. At the Thailand, you would also put there. Thank you. See you. Don't get to answer our evaluation form. Take care, Fatima. Bye. I am also sending the slides of Sameer so that you could email her. Bye. Yes, Happy New Year to those who are celebrating Khmer New Year in Sri Lanka, Bangladesh, Cambodia, and Thailand.
Bye. Bye.
Thank you very much.